What a pleasure to be here. Let's just do a huge round of applause for the audience here. And what a privilege it is for me to have this conversation with Scott, who has been a big champion of our work at Stanford by Design and of course, been a big champion of innovators in the health technology industry. Scott, as I was thinking about, this conversation, as preparing for it, I realized some of the work that you did actually fits with this philosophy or this concept of reimagining health, which is this book that I showed you. And it really talks about how healthcare really needs to get closer to people. And a lot of innovation that we are seeing right now, a lot of technologies that we are seeing right now, seem to be enabling that. And a lot of work that you did as the FDA commissioner actually facilitated the digital health solutions, the software as a device. A lot of guidelines that came out, the rules that came out were very much enabling of, and we are starting to see the benefit of all of that in the AI era. Could you talk a little bit more about that era and what you did and how that sets us up for the next wave of innovation that we see?
Yeah, and thanks for having me here tonight. I think when I was there, we recognized that we needed to think differently about how we regulate medical devices that were going to be used by consumers to help inform their health, help inform treatment decisions, that would allow providers to move more care into home settings and into the community-based settings. And I think an inflection point for us really was the Apple Watch, because what traditionally, FDA would regulate a medical device by looking at the hardware, validating the hardware itself, validating the software embedded in the device itself. And when we received the application from Apple for the watch, what we saw was that the validation work that they had done was so exquisite and so exhaustive, we started to ask ourselves, why were we regulating this as a traditional medical device and looking at the hardware? And a lot of people felt that FDA would never be able to approve the Apple Watch as a medical device at the time because they said, well, FDA will try to rip apart the Apple Watch and figure out how the circuits work, and they're just not going to be able to figure it out, and they'll never be able to do this. And what we said to ourselves is what we really should be doing is regulating it based on the validation work that Apple had done and not on the device itself. Apple must have set up in Cupertino 10,000 people on treadmills inside their headquarters, their employees, and must have been looking at their outputs from these Apple Watches over a period of years or a long period of time and correlating with EKGs and other parameters to be able to demonstrate that these were reliable measures of cardiac output. So it was an exquisite amount of validation work they had done. And that really birthed the concept of a firm-based approach to regulation, where we said, instead of regulating the tool itself, we'll regulate the firm that's bringing these tools to the market, and that way they can allow new versions of these tools into the marketplace. They can undergo constant iterations, as a lot of software-based devices have to do. They can even come to the market with brand new devices and concepts, so long as they've done the same level of validation, and we'll regulate them based on what they're doing to validate these different tools. And so it was really a change in the mindset of the agency. And you started to see that codified in things like how we approached in vitro diagnostics, where for the first time, when we rolled out a new regulatory scheme to regulate diagnostic tests that would also be used to inform physician decision-making, but in some cases to inform consumers directly, we took this same concept forward, this firm-based approach to regulation, ultimately enshrined it in a piece of legislation that we helped write, the VALID Act, which was a new concept about how we would regulate diagnostic tests. I think, unfortunately, a lot of that didn't go forward for various reasons. I mean, the legislation failed to pass, and we really saw that legislation at the time as an important framework for how we would start to regulate some of these consumer-based tools, these apps we were seeing, medical hardware, wearables. And then when the FDA tried to promulgate a similar concept in regulation, they ultimately lost in court. They were sued under the Biden administration. It was struck down in a northern district in Texas. The FDA was going to appeal in the Fifth Circuit, but ultimately didn't. And so I think it's a very unsettled time for what the agency's authorities are and what regulations they could actually put in place to be more accommodative to a lot of what we're seeing right now. So I think that the impediment that we have right now to kind of bringing forward this vision that you've talked about in the book, really is a regulatory scheme that I think isn't modernized to fully accommodate it. And I don't think that, I'm not seeing the policy making that would happen quickly enough and as innovative enough to really unlock these opportunities. And I think the agency's hands are tied in some respects, and I think ultimately it's going to require legislation. Congress is going to have to rethink a more modern framework that appreciates what the opportunity set is. I'll give you sort of an anecdote. When I was there, literally one of the last things I put out, I wanted to make sure it got out the door before I left. So this was after I had announced that I was resigning, was a white paper on how the agency would approach the regulation of AI medical devices. And I will tell you, I think if you go back and look at it now, I think that there's some, conceptually, I think we envisioned part of what the future could enable, but nobody envisioned ChatGPT, nobody envisioned how informed these tools would be, how quickly, and how impactful they could be. And so, you read that now relative to where we are today, and today we have this whole different opportunity set relative to kind of what we were conceiving in this white paper about 6 short years ago. And in the intervening years, there's really been, I think, minimal policymaking that would help, sort of animate that framework that we envisioned and certainly accommodate what we have today.
This is very interesting. Regulation as enabler or regulator as enabler. I grew up in India in colonial era rules, where regulation were meant as barriers, and we are seeing a little bit of that in Europe. But you saw regulations differently. Your team saw it differently, and that led to a lot of the progress that we saw. It seems like it's been a bit of a seesaw. You talked about hands are tied. FDA's hands are tied. What stands in the way? What will sort of continue to move us down the path that we need? Because we see tremendous opportunity, and if we don't do regulations differently, we would be in the same place where Europe is today.
Yeah, I think there's a number of things that stand in the way, and I wouldn't discount the cultural barriers and also the challenges working in a regulatory agency where you worry about crosswalking accommodations you make in one realm into another and what the implications would be. So, if you make an accommodation in one context, unless you've come up with a very discrete definition of what it is that you're regulating in this context and why you're treating it differently, what are the implications for your authorities in a similar context? And so that's a real impediment to the agency defining something that's conceptually very new with respect to how it treats AI-enabled medical devices, wearables, things like that. There's cultural impediments insofar as the agency jealously guards devices that are going to measure certain parameters. So blood pressure, for example. Blood pressure has been something that the agency always has maintained very tight vigilance over the accuracy and the clinical validity of tools used for that. And so when you move into a Whoop, which I'm wearing, not tonight because I actually left it home, is the agency going to apply the same standards for that medical device, which may not be as sort of sensitive and specific as something that's used in a clinical setting? Even though a device used in a wearable setting, even if it's, has wider variance, it could still be very important. It could be important in terms of providing a baseline and showing when the patient's blood pressure varies from a baseline and circumstances in which that does. And so you need to think about it differently, but if you have a single standard for how you measure something or how you think a device should be measuring something, you apply it across the whole continuum, it could be an impediment to trying to move these things into more austere types of settings. And then there's also, talking about the cultural impediments, there's a cultural impediment around the idea of putting information in the hands of the consumer and how will that information be used. And this has been a long-standing I think, challenge for the agency that it has, over time, I think, made a lot of accommodation for. I remember I was there in the early 2000s, and I remember the debate over making available tests that would allow people to test themselves for HIV in the home. Initially, a pinprick and a card that you would mail in, and whether or not we can do that outside of a clinical setting where a patient might not have access to proper counseling, and what would the implications be. And people worried that if a patient was able to sort of self-diagnose outside of a clinical setting, then they might, take actions based on that information. They were worried about self-harm in those circumstances. And if you sort of step back and you look at that question from a population standpoint, rather than thinking about the individual scenarios where things could go awry. From a population standpoint, if we had tools available that allowed many more patients to get diagnosed for HIV and patients who may not feel comfortable going into a clinical setting but would do it in the confines of the home, that's going to have a profound impact. You saw the agency taking that more of a sort of global perspective with respect to the impact that different tools could have if you made them widely available, instead of looking at single scenarios, but thinking about it at a population level in the context of COVID. When they thought about, when they, for example, made available home tests for COVID and now influenza A and B, at the outset of COVID, I was really skeptical that they would ever approve a home diagnostic for a communicable infectious disease. Like that concept, when I was at the agency, would have been an anathema among many people, because they would have been worried that people wouldn't self-present, they wouldn't get properly diagnosed and treated, they might get false negatives, they may not take appropriate action, continue to spread the illness in a home setting if they're self-diagnosing because they're not getting properly counseled by a provider. And FDA stepped back and said, if we can make these tools widely accessible, sure, there's going to be circumstances where they're not used appropriately, people don't take appropriate action, they don't present in a clinical setting and get appropriate care, but at a population level, these will substantially reduce the spread of disease. And so you see the agency's mindset evolving, but I think in this context, it's not evolving quickly enough relative to the opportunity set. And so this is where I think Congress really could play a role. Maybe not Congress right now, but Congress in the right environment, I think, could play a really constructive role. And there's good members who've thought about this on both the Republican Democratic side. There could be a real opportunity if we work on legislation that creates a new framework to get it in the next round of the user fee reauthorization, which is just a couple of years away.
So today in my class, I think I told you this class that I teach at Stanford, we had head of diagnostics at Abbott come to class today, and he talked about a couple of examples that you just talked about, a remarkable change of mindset. And a really good example of that change of mindset is in the breast cancer, the MQSA, the Quality Safety Act that you sort of standard act that you promulgated, and that enabled access to breast cancer screening closer to home. And I don't know what the numbers are, how many women have benefited from that act, but it could be tens of thousands or hundreds of thousands of women whose lives might have been saved because of that. Can you talk a little bit about how that came about? And I remember reading in the media at that time, there was some pushback, but fortunately it came through, and it's really enabled innovations like iSonos. So talk a little bit more about how that came about.
Yeah, so this was controversial at the time. So this was a regulation that had been drafted years earlier and was controversial on Capitol Hill and was controversial within the agency because the concern at the time was that we would be making certain information available to patients and providers that people worried would potentially lead to overdiagnosis, over testing, that it would obviate people into certain, additional imaging, biopsies that they may not be indicated for. And so, but to us, I will say by the time I arrived at the agency, the mindset of CDRH had really changed around that, and Jeff Shuren had become a champion for this. And so I had internal champions among the professional staff who wanted to see us move this, knew that there would be external resistance, including on Capitol Hill. We had a little bit of resistance on Capitol Hill. But the mindset had changed that, we felt, and my team felt, if there's information available that could help inform decisions, we can't be absorbed by the outlier cases where it may lead to certain decision-making that some providers or some observers think maybe wasn't indicated, but think about all the circumstances where it could help better inform a decision, and also recognize that there's going to be more tools that become available that allow better interpretation of this information, allow it to be used more effectively in a clinical setting. When you make the information available to consumers, people are going to build algorithms around it and build systems around it to use it in a more constructive way. And so, we ultimately got the regulation out. I remember meeting with a lot of the groups who were skeptical. There was a lot of consumer groups at the time, and also some healthcare groups that were worried about potential implications for cost to the system. And they came around, and by the time we got it out, I think that there was pretty uniform support. There certainly wasn't vocal opposition, but we really worked with people to try to inform them about why we felt the circumstances had changed, and this was an important thing to be made available to consumers. But it really got back to that issue of if there's information that could be available, do you worry about the circumstances? As long as the information is accurate, as long as it's clinically valid, should the agency be in the business of deciding clinical utility and deciding how that information will be used? And I think we're in an environment right now where there's so many tools that can help synthesize information and inform judgment based on information that you want more information, not less, in the marketplace. Things have substantially changed, and I think that not only the tools better, but the systems are better. And so we need to always be leaning forward to try to do that. And this is another thing that comes up in the context of in vitro diagnostics, where we literally had panels that we were clearing where we knew the panels could read out, 100 mutations, but only 10 were demonstrated to be clinically relevant. And so we were forcing product developers to hide the 90 and only report the 10. And to me that, I'm kind of a libertarian, and to me the idea of suppressing information that could be clinically useful to certain people and certain providers who are, sort of instructed and trained on how to use this information, how could we be doing that as a regulatory agency? And I think that mindset has changed and is continuing to change, but that's going to be the important cultural barrier.
So we're out of time almost, but I would end with this last question, and I promise you that I'm going to ask a controversial question, and I will. As you as you look to the future, what excites you? And, in the context of the innovators that you see in the room, and you as an investor, what excites you? Where does the future go? And the controversial part is this: if the president today invites you back to take FDA, the reins of FDA, what would you do?
Yeah, so...
Do you like that question? You like that question?
Look, honestly, I think that I think I'd pick up where I left off. I think that there's, obviously the circumstances have changed. The opportunity set's much wider right now, but I think the opportunity to go in there and try to develop policies that would allow more of these tools to reach consumers and providers is really seductive. And the pace of the medical change just in those intervening years is in a direction that we never could have envisioned. I mean, we were, like I said, when we were putting out that AI white paper, we never could have envisioned a large language model that you can interact with and ask structured, unstructured questions to. So I think that there are ways to try to use the agency's authorities to pilot approaches that would make the agency less of a pre-market regulator and more of a post-market regulator with tools that are informing patients and providers and providing information into circumstances where otherwise decisions are going to get made in the absence of that information. I think there's things FDA can do, but I think you really want to legislate these things. But what I would do is do what we did with the Valid Act. I mean, we really, we wrote that bill in concert with Congress. One of the virtues of working in the first Trump administration was that there wasn't a lot of kind of regulation on what agency heads could do as long as the White House had confidence in an agency head. I was able to do things that I wouldn't have been able to do when I worked in the Bush administration. Like the idea that I would work with Congress to craft legislation in the Bush administration, if I had done that, I would have been fired. But in a Trump administration, as long as you kept the right people informed, you didn't have to put it through interdepartmental clearance and White House counsel per se. They allowed us to work on things with a degree of independence. I remember someone said to me when I first came aboard in the Trump administration, this is going to be a great administration to work for. You're going to have a lot of independence. You just have to tolerate a ceremonial firing every now and then. So we were able to work with Congress to craft that bill, that Valid Act. And I don't think that ever would have gotten out in another administration where there would have been a lot of interdepartmental clearance. You would have had to worry about CDC's equities and NIH's equities, and every other agency would be trying to make sure that their interests are represented in it. CDC probably would have given us a hard time about getting that bill out. So I think that there would be opportunity to try to advance some of these things legislatively, and I think there's people still on Capitol Hill who would be interested in doing it.
Well, this really concludes our time here, but Scott, thank you so much. What an exciting conversation. And my hope is the seeds that you sowed actually continue to sort of bear fruit for all the innovators in the room, all the investors in the room as well, including yourself. Thank you.
Great.